We have Dr. Sujatha Mohan, Associate Medical Director of Rajanekar Hospital, and she's going to talk to us on fixing
dislocated
management of subluxated IOLs. I've been to know fixation, most of the external fixation. Yeah.
Thank you, Dr. Mohan. I'd like to thank APAO and AIOS for this wonderful opportunity. I'm just going to show you some case scenarios in which we have fixated wobbly IOLs or dislocated IOLs. So case 1 was a 70-year-old male who had a phaco foldable done 15 years back by us, had excellent vision of 6/6, no history of trauma, but he complained of oscillopsia or some shaking vision. And on examination, he had pseudo-exfoliation. You can see the video here showing that how the lens is moving. This is you can see that's a multi-piece lens. It was even before the era of foldable lenses. So we decided to fixate the same lens and prepare the eye to receive to convert this lens into a glued IOL. So you can see I'm using a posterior infusion. Also, I'm having I've already made 2 flaps, made the Chariot's pockets. Now what I'm doing is I'm lifting the lens out of its position. You can see how easily it is coming out. Absolutely, there are no zonules. But it's very important that it doesn't fall into the vitreous. So you have to very carefully place it on top of the iris. I'm trying to remove the capsule, but it's not possible. So I'm going to use a vitrector to remove the posterior aspect of the capsule. So basically, we want to remove the lens out of the bag. So initially what I'm doing is I'm just creating a posterior capsule, just eating away the posterior capsule. And now I'm just feeding the lens into the what is called as a handshake technique. I've just exteriorized one haptic. At the same time, I'm holding the lens on the other side. And you can see now I'm exteriorizing the other haptic. So there are some remnants of capsule still present which has to be removed using a vitrector. In this case, we didn't have any vitreous loss, but I did use a vitrector because I had to remove all the capsular remnants. So now the lens has been tucked into the Chariot's pocket, and I'm doing a minimal vitrectomy to remove all the capsular remnants, and after that the case is closed. So this is a post-operative video of the same patient. This is after the glue has been placed and the flap and the conjunctiva is glued. Okay. So this is a post-operative video of the same patient. You can see that on movement of the eye, there is no movement of the IOL, and he regained a 6/6 vision. And he was very comfortable with it. We have almost about 7-8 years of follow-up with this patient, and he's doing very well. So the next case is a very similar case, again a 75-year-old male with a drop in vision which is worsening over a period of 2 months, and we found this was a dislocated IOL bag complex, and this was a single piece lens, and you can see that the lens haptic optic junction is seen in the visual axis itself. So in this case, I decided to go in for a Hoffman's pockets. So just to give us a brief explanation about Hoffman's pockets. So you can see that here I've created, there is an incision which has been created here, and a scleral pocket approximately about 300 to 400 microns depth is made from the corneal side. So you're not opening the conjunctiva. There's always a risk of bleeding. Then you make 2 across each other. You can make it a 3 and 9 o'clock position. And after that, you introduce a 26 gauge needle and thread the 10-0 polypropylene through it. One of the sutures go on top of the haptic, the other one goes below the haptic. You can see that. So a nice loop is formed, and this is done on either side. So when you pull the lenses together, it comes to the center. So this is so finally what you do is you retrieve the suture from under the pocket and tie it. So this is how a Hoffman's pocket is created, and I'll show you the video. So this here you can see I'm creating a Hoffman's pocket, and the most important thing is while creating the pocket, you have to make sure that you have adequate space. If you don't have adequate space, then you might be inadvertently putting the needle through an area where there is no pocket. So you have to check the pocket. Now I'm making a you can see I'm going through with a 27 gauge needle, and I'm threading the 10-0 polypropylene into it, railroading it, and I've made one loop. Now the second end of the needle is going, which is going on top. The first one went underneath, the other one goes on top, whichever way you want. And you can see the lens is being pulled towards one side. And now you leave it like that. You just trim the sutures and leave it like that. You can tie it at a later date. So now you can come to the other end of the haptic. So here in this case, what I have done is, so you can see again, this is going at the bottom. So you have to do exactly the reverse of what you did on the other side. That is, if you put on top first, then this one comes at the bottom. So again, the next one is going on top of the haptic, and it's railroaded, and now you have a loop around the haptic on both sides, which is exteriorized. And once you adjust the lens, you can just tie it together. You adjust the lens so that you make sure that it's in the center. Always, whenever you do even if there is no vitreous presentation, it's always better to check for vitreous presentation in these cases. And you can put some tricot and check for the vitreous presentation and then complete the case. In this case, I was planning for a glued IOL but converted into this, so I used the glue to seal the pockets, but that's absolutely not required. So this is again a third case where the patient had lens fixated 3 times, because there is definitely a rim of capsule all around, but every time it was fixated, I think it decentered, because either it was not placed properly, or the capsule was not strong enough, or the space was not good enough. So this time we decided that we will do a glued IOL, because patient wanted to end off, and he said, I have come to you because I want a complete solution to this problem. You can see that I'm removing the capsular contents, and you can see the handshake technique, where the haptics are being exteriorized using a MST forceps. And again, the other side, it's being exteriorized. In this case, I'm using an AC maintainer. It's very important, either use an AC maintainer or use a posterior infusion. You need to have an infusion on, and now it's tucked into the Chariot's pockets. A little bit of iris prolapse, actually you really don't have to worry about. You can always tuck it back in, and you're going to anyway glue the flap. And the glue is, and the procedure is completed. And the patient again has a follow-up of about 7-8 years. The last case I'm going to show you is where I have used a slightly different technique. I did start with doing a glued IOL, but then I decided let me use a Gore-Tex suture to reposition the lens, because this patient also has a single piece lens. So single piece lens, if you're going to, you can't glue it, so you'll have to remove it and then replace it with another IOL. So in this case, I decided, let me do a Gore-Tex suture fixation, because that is much more stronger than 10-0 polypropylene, which can erode over a period of time and again cause dislocation. So Gore-Tex sutures are being used widely now for this type of procedures. So you can see, I'm just taking the Gore-Tex suture and retrieving it from under the haptic. So the one portion of the Gore-Tex suture goes under the haptic, the other one goes on top. So you have to make a myringotomy incision, because it's a slightly larger suture, it is very thick, and it has to be, you have to make a larger incision. The same thing is repeated on this side. The first one goes on top, the second one goes to the bottom, so that there is no torque of the lens, that a lens doesn't twist. Now that you've got both of them outside, you center them well, and then you do the tying. So you just tie it. You can rotate the knots into position, but if you have not made a flap, you can, otherwise you can just leave it and glue the flap. So in this, you can see that it is very nicely done. And there is a large sommering ring there which has to be removed. And so that's what I'm like I told you, we do put tricot to see if there is any remnant vitreous or some vitreous presentation. And once we got the sommering rings out, we did an anterior vitrectomy and removed, using a vitrector, we removed the sommering ring. And I'm just checking to see if there's any vitreous, and just tightening the sutures. You can, actually it will be better to bury these sutures, because they are very big and the knots can be quite big, but because it's under the flap, it's okay. So now I've glued the flap and also the conjunctiva, and the procedure is complete. So the summarizing, dislocated IOLs can be managed in many ways. Techniques depends on the surgeon's expertise, the type of IOL, and the complexity of the case. Thank you.
Thank you, Sujatha. I think wonderful videos and very nice explanation and how to do the ab internal fixation, either sutures or Gore-Tex and or glued IOL techniques. I think it's it's not very difficult. Everybody can do this technique. It's only certain basic protocols have